I think, finding people that are subclinical, people that, have infection, but they do not present with symptoms. So by finding these people, we can see how they would progress from infection to active disease. And if we can find them early enough, we can start the intervention early enough and then prevent transmission of disease.
I think another important question for TB research right now is the development of a new vaccine, because we currently have a very old vaccine, more than 100 years old, called the BCG vaccine. Mm-hmm. It works in young children to protect them against TB, but as they reach adolescence, the vaccine is no longer protective. And so we need an urgent vaccine to help prevent TB. We're doing a lot of work in our lab, clinical research on TB, and there are multiple projects currently going on. So for my aspect, or my research specifically, we're looking at developing tools to diagnose TB in young children, very young children. And this is a difficult group to work with because they do not produce sputum, and the sampling methods are very invasive. So we're looking at new tools to develop to detect TB in this vulnerable population. In addition to that, what we're trying to do is look at the oral microbiome of young children and how this impacts TB treatment and progression of TB and treatment outcomes. So that's something that I'm specifically focused on, in addition to all the other things in the lab.
Okay, so I think the other main focus that we currently have in our lab, which we have spent almost a decade looking at, is this concept of differentially culturable bacteria. Traditional routine culture generally picks up just the viable bacteria, but we know from the research we've done that that's not the only population that we see in sputum. And there's these organisms that are hard to cultivate using routine culture, and we have developed a specialized assay in the laboratory to pick up these differentially culturable bacteria, or called DCTB. And the more research we have done or looked at more cohorts, we find that these are actually the persistent bacteria that are hanging around and may be implicated for relapse disease, for recurrent disease, and treatment failure. So that's a very big step in the TB field to understand the total population that's in the sputum. So I think it's advancement in molecular diagnostic. For example, GeneXpert, that just enabled rollout of GeneXpert, just allowed us to detect TB faster. We were able to now detect resistance at the same time. So this means that we're getting faster diagnosis, and then that allows you to get the patient faster onto treatment. And the second advancement, I think, is genomic sequencing. By able to do high level or deep genomic sequencing, we're able to now track transmission and in communities, within households, and map transmission that occurs between these individuals. And that's giving us a much better picture of how the disease is progressing.
To add to that, I think another advancement is that we do definitely have the development of new vaccines. They are currently being tested. So these are your BCG-based vaccines, M72, but we also have mRNA vaccines which are being tested. So an exciting, I wouldn't call it a breakthrough yet because the results are still pending, but we do have exciting options for new vaccines in TB, and the results for these will be released in the next year or two.
And I think the role of AI is becoming quite important in our research as well, because AI, can give us better ways of detecting or examining an X-ray, get a deeper sense of what's going on. We can predict models to say who's at risk of developing TB. How do we get them on better treatment options? Who needs what sort of treatment? So maybe like a tailored regimen for certain people in the population. So AI has definitely got some place in, creating models for TB management.
Yeah, you said the genomics platforms, these generate a lot of data. And so AI possibly can can you utilize that data more effectively than people can? Because large data sets need to be made sense of, and so AI would play an important role in that as well.
I think we have gained a lot of traction and momentum, definitely, in this last couple of years. Like you mentioned previously, there are several promising candidates that are in late phases of trial. And so we don't have one yet, but it's on the horizon. I think we should be in the next 5 to 10 years be able to reshape prevention of TB.
Yeah. And just to note as well that implementation of a vaccine is, even though we may be close to it, we still need a lot of efficacy and safety trials in humans for this to be actually implemented in a clinical setting. So I agree with you, it's another 5 to 10 years. TB is a problem in South Africa because firstly we are a very high burden setting TB, and I think that's related to several factors. The first being socioeconomic factors. There is a high burden on a healthcare system that does not support them properly. It's sometimes under-resourced as well. And I think that that impacts how we treat TB very dramatically. It's also it's a decentralized healthcare system, and so to manage TB is difficult in that setting. Also, we have a high burden of HIV co-infection, and these two diseases, when they go together, one drives the other. And so because South Africa has such a high burden of HIV, it's very difficult to control the TB pandemic as well.
Yeah, so I think, the socioeconomic problems that we deal in our country are of poverty, firstly. So when people are not nourished well enough, they're going to, be getting sick. Overcrowding, so that certain communities are more prone to getting infected by each other because there's just so much of overcrowding, lack of water, hygiene. So those are all contributing factors that lead to this high burden of TB within our communities.
HIV co-infection with TB is very difficult to manage, and HIV complicates it because the virus infects the human immune system, and because of that compromised immune system, TB is difficult to control. Another way that HIV co-infection impacts TB is that you have to be very mindful of the interactions between the two drugs that are used, or the types of drugs that are used to manage both infections. You could this could result in adverse or toxic side effects if the medications are not managed correctly. I think from those two aspects, HIV infection complicates the management of TB.
I think, our studies on transmission, firstly, have really shed a lot of light. It's shifted the needle in the field because we were able to now link certain individuals or index participants within a household that's spreading the disease, and understand why certain individuals are only getting sick and not others in the same specific household. And together with that, I think looking at immunology, the lung biome, be very diversified in the way we're approaching our research. And that's allowing us to get better understanding of just not the bacterial burden, but also the immune responses that are occurring amongst these individuals. Looking at subclinical TB is very important because if we can find these people early enough, we can put them on treatment or the right interventions and don't put everybody on the same sort of regimen. So almost like a specific tailor-made kind of approach. So, that's like our kind of next steps to understand that early detection is very important to prevent transmission and to ultimately eradicate the disease.
It's important for policy makers to prioritize the importance of active case finding, because transmission of TB happens when a person is very sick, and oftentimes it's too late to find the TB. So if we can look for people who are exposed to TB firstly, and then find those people who are not presenting with any clinical symptoms yet, despite being able to transmit the disease. Those types of changes in policy will help us detect and treat TB a lot quicker and a lot more effectively. And I think in the context of South Africa with a very high burden of TB, that type of policy change will make a meaningful impact, because we're finding those people who are not presenting to the clinic despite having TB and transmitting TB. So for me, that is a very important policy change that could be meaningful for South Africa.
One other area that I think needs attention is also to get quicker diagnostics into the communities. So, and that are not sputum based, that are alternative specimens or ways of detecting TB, so that it's done within the community. They don't have to go to the clinics, and a lot of people don't utilize the clinics, or they don't want to go because of stigma, etc. So I think that would really enhance, if we can get the two together. So I think, like we said before, we should move beyond waiting for people to present at clinics. We need to do active case finding. So if we go into the communities and have a system that's implemented where, a certain household, there's an individual that's already ill, we should have mechanisms where that household is being tested. We don't wait till the next person is going to get sick and then wait. By then, if it's a subclinical situation, that person would have transmitted already within that community. And this is how we then cannot understand exactly how the disease is progressing or moving within a community.
Yeah.
So definitely, I think we need to do more active case finding and within communities.
Right, and I think to add to that also, communities have to become partners in finding solutions for TB. That stigma that you speak about is still very rife in communities, and I think people need to be educated to remove that stigma, find options of getting treatment, because the sooner you get treatment, the better. And if you're exposed, even if you think you're exposed to someone who may have TB, it's very important to advise that person to get tested, and you yourself get tested. Because the sooner you can get diagnosed and the sooner you get onto TB treatment, I think the better for curbing further transmission of the disease. So communities play an important role, because healthcare workers cannot be everywhere at the same time.
Exactly.
So they have to partner up with healthcare and in that way combat the disease from both fronts. I think that's an important aspect as well.
And I think it works both ways as well. So in return, when there is an advancement or an innovation, if communities are engaged, the scalability or the implementation is also much easier, because we already have them on board. So implementing these new innovations can also be of great benefit then within communities if we have a good partnership.
Right. The drug resistance in TB is a very serious problem, in the fact that it's constantly, the amount of drug-resistant infections is constantly rising. And so it is a problem because the current drugs may not be effective in treating TB and the drug-resistant TB. And so to treat those types of infections, we need a lot more, we need drugs that are a lot more toxic potentially and take longer to treat. And so because of those facts, drug resistance and the emergence of drug-resistant TB is a very critical factor in the management of TB disease.
TB is a curable disease, and definitely the drugs that are prescribed for drug-susceptible TB, they work. They protract it for 6 months, but if the patient adheres, they take it, as they prescribe to take them and complete the course, they will be cured. The same cannot be said for drug-resistant TB for the various reasons that you just mentioned. And the drug-resistant regimens are becoming smaller and smaller. We don't have many options left now, and if we do have those drugs, they're quite toxic, expensive, take longer to treat, and then usually the outcomes are not that good. But for drug-susceptible TB, I think we still stand a good chance.
There are some existing trials and evidence in the literature to show that we are moving towards shorter treatment options, particularly for drug-resistant TB. And this is known as the BPAL treatment, where they've reduced 2 years of treatment down to about 6 months. So there are active studies looking at shortening TB treatment. But this is still ongoing because you have to find the best combinations of drugs. And like you mentioned earlier, perhaps tailoring to a specific patient. If that patient develops resistance to a particular drug in that regimen, you have to take it out. So it's not as easy as changing drugs to this. You have to make sure that those drugs remain effective over a shorter treatment time. So we do have work going on in this field, but it's also very complicated because you have to manage it on a patient-to-patient basis.
I think very important. Both institutions, they play different roles, but I think it's for research to integrate the research into policy, into scalability. NHLS and BITS, they both play a very important part because that's where the research then can get integrated, and it can make the difference at the end, rather than it just staying within the research environment.
I think also your points are excellent, and I think to add to that, innovations and new drugs and new ways of combating disease are going to be found in research settings.
Yes.
Because from the molecular perspective, trying to understand how the bacteria works, our research looks at finding new drug targets, for example.
Mm-hmm.
And so those can only be tested in a research setting and not in a healthcare setting, for example.
Exactly.
And so your point to say that the link between the two is important is true, and it cannot be underestimated. And so we have to leverage our partnerships with the NHLS and other healthcare settings because they have access to large-scale samples. Mm-hmm. So we can, in the research lab, look at those samples and study the individual specimens of TB for individual patients. And so there, like you said, we can link the two together nicely to implement policy changes, to implement new treatment options, for example. So, agree fully.
So I think we've done well, like for example with the gene expert, but I think still a lot more needs to be done. And I think, policy is also dependent on what we get out of the research and whether it is innovative, it is applicable, can it go into policy making, can it change? So it's a two-way thing. But definitely we need to do a lot more in that area. And the other thing I think that also plays a huge role is funding. HIV has been, very well funded for most of its time, whilst TB has been the poorer cousin. And yet the two diseases are interlinked. So we need to, look at them together and not in isolation. So funding can also be a bit of a setback when it comes to TB because we're not always, being able to do these long cohort or longitudinal studies that we wish to, because they can go into years before we can understand. TB being a slow grower, and treatment takes 6 months, so you want to follow up maybe for a year, for 2 years. So that's all very expensive, and we need a lot of funding to do those kind of studies. And so I think policy and funding goes hand in hand.
Communities have a very important role to play in TB research from multiple factors. The first being that any research that is done in communities need to be involved from the beginning. Because if they're involved from the beginning, you'll get the buy-in from the community, and implementation of any findings will be more readily accepted and adopted in the community. Secondly, communities need to work with healthcare facilities for recruitment purposes. People need to go to the clinics to get tested, and they may even refer people to clinics for testing. So without that additional support from the community, we still miss TB because you can't be healthcare workers can't be everywhere at the same time. So we rely on communities to support recruitment of people who may have TB and to allow them to go to healthcare settings for further testing.
So they're very central to both research and implementation, because if they don't give us a sample, we cannot do the research and we cannot find new innovations.
So what gives me hope in the fight against TB is that we are getting very, very cool, advanced tools to fight the disease. With the implementation of new genomics tools, we can find new drug targets quicker. I just think the pace of the development of the various tools we have is very exciting because it helps us to move a little bit faster towards eradicating the disease. In the next 5 to 10 years, I see TB research moving into a very integrated space, and this is making use of both new vaccines, induced immunity, together with host-directed therapies for TB. So if we understand how the immune system works from the host perspective, and then combining that with the new vaccines we're developing, those two combined may produce more effective treatment options. And I think that's where the TB space will be, is very integrated using these genomics platforms, these new vaccines. And we have to integrate it because TB treatment needs to be individualized so that it works effectively for every single person being treated for TB.
I think having done this first transmission study over a 16-month period, we just sort of touched the tip of the iceberg in understanding TB transmission. And we definitely need more cohorts that can expand even longer than 16 months because to understand disease outcomes, who's going to need further treatment or extended treatment, etc., who's subclinical within households. So definitely setting up more robust, longitudinal cohorts that are going to address these kind of issues of bacterial load, who's transmitting, who's not transmitting, where the epidemic is moving within a particular community, what are the treatment outcomes, and that will just give us a better understanding of how the disease is moving within the community. So we definitely need to set up more of these kind of cohorts, and because also at the end you start up with a big number, but then you lose a lot of participants along the way because they either terminate or for whatever reason. So at the end, your analysis is again very small, with a very small number. So definitely we need more larger studies. Yeah.